very warm welcome to everybody for this month's webinar on myelofibrosis. I'm Nona, I'm co-chair of MPN Voice, and it is really a great pleasure and great thanks to Dr. McLornan, Dr. McGregor, Dr. Godfrey, Dr. Kahn, and not forgetting our patient speaker, Don Glossop. We are delighted to welcome you all, and it's good morning, good afternoon, and good evening, because we have people logging on from the USA, Canada, Ireland, Spain, the Virgin Islands, Indonesia, Angola, and France. And for some of you, it's a first to come onto an MPN Voice webinar. I'd like to extend you a special welcome. MPN Voice has a number of things that it does, and I would suggest you clock onto our website, mpnvoice.org.uk. That will give you a full view of what we do. Now, just a little bit of housekeeping. There are some wonderful slides that you will see tonight, but we do have to ask that if you do take photographs of them, they can only be for personal use or reference. That's due to the laws here on data protection, and they're not to be posted on any social media platforms or websites or online forums. The panel Q&A session, the speakers will answer questions during the panel Q&A, but they can't answer any personalized questions regarding your treatment. Please take those back to your own team. We just also ask that any feedback we would welcome. We're here to meet the patient community needs, and we would be grateful if you could complete the feedback survey, which will be available at the end of the program. So without further ado, I'm going to ask Dr. McLornan to introduce the program. Thank you.
Thank you so much, Nona, and thank you everyone for attending this afternoon, which I hope will be a really exciting chance for discussion. So I'm delighted to be joined by Dr. Godfrey, Dr. McGregor, Dr. Kahn, and Don, our patient expert. And we're really going to focus today on myelofibrosis. So Andrew is going to bring us through blood and bone marrow findings, so how we diagnose myelofibrosis. Anna is going to discuss molecular testing and introduce a really complex area of prognostic scoring, which is super important. Alesia has the tough task of covering treatment options, both current and what's coming in the future. And to finish, on the treatment part, I will discuss accelerated transformation of myelofibrosis and what the therapeutic options are then. And then we're very grateful for Don joining us, who will discuss his experience of being a patient with myelofibrosis and being on clinical trials. And then we'll finish with a panel question and answer session. So thank you so much. And without further ado, I will hand over to Andrew. So I will stop sharing slides and he'll start to bring us through the diagnosis of myelofibrosis and what we see in the blood and bone marrow. So thank you, Andrew.
Excellent. So yeah, I'm going to go through some of the things that we will look at when we're diagnosing myelofibrosis. But before we get to some tests, it's important to talk about the symptoms that people might experience. Some people, this is picked up by chance, found incidentally. Some people, we know that they've already got an underlying myeloproliferative neoplasm, normally essential thrombocythemia or polycythemia vera. And over time, those diseases can change and become myelofibrosis. So that's a sort of a progression of the underlying problem. But some people get myelofibrosis from the start, and some people will complain about weight loss, night sweats, where they're drenched with sweat, tummy pain, usually because they've got an enlarged spleen and the spleen is taking up too much room in the abdomen. Some people also complain of feeling full quite easily. Again, that's because the spleen squashes against the stomach and it means you can't tolerate large meals. Itch is a problem in some patients, bone pain, fatigue is a major problem in a lot of patients, and some people may have blood clots as well. So those are the sort of symptoms that might point us in the direction that someone might have a myeloproliferative neoplasm. And then the next step that we would go down is we would do a full blood count. Now, the people on this call with myeloproliferative neoplasms are often very familiar with their own blood count and the terminology. And if you're not familiar with it because you're relatively newly diagnosed, then often people do become very familiar with these numbers. So the things that we look at in the full blood count, the first thing that we often look at is the hemoglobin. Hemoglobin is a type of protein that carries oxygen from the lungs to the tissues, to individual cells. And in myelofibrosis, that's often low, so people are anemic. The white cells is another thing that we will look at in the full blood count. The white cells are primarily there to fight infection. In myelofibrosis, they can be high or they can be low. They can be either. And then the last thing in the full blood count is the platelets, and the platelets are the little cells that help the blood clot. And again, in myelofibrosis, they can be high, especially at the start, they can be high or they can be low. But as the disease goes on, often they do reduce over time. So once we've looked at the numbers that the machine gives us, we look at the blood under the microscope, and it's a pretty simple process that we've used for years and years and years. And the first thing we do is we slide the blood on a glass slide, and then we stain it to make sure we can see the cells. Actually, the machine does a lot of this for us now, but we can do this manually if we want as well, if we want a quicker result. And then we look at it down the microscope, and I'll see if I can use the pointer. The cells in red are, unsurprisingly, the red cells, which carry hemoglobin. The platelets are the smallest things. You can see these little small purple dots dotted around. And then this is one of the white cells. This is a neutrophil. So this is a normal, the appearances of the normal blood. And then in addition to the neutrophil, there are different types of white cells. So we've got a neutrophil at the top, then a lymphocyte, an eosinophil, which is sort of an orangey red color, a monocyte, and a basophil. So those are the different white cells that we will see in the blood, in a normal blood film. So what happens in myelofibrosis? What are we looking for? And we will often do this in people with ET or PV as well, just to see if the blood or the bone marrow is changing. This is one of the first things, the easiest thing that we can look at before we go to a bone marrow biopsy. But instead of the red cells being nice and round, you can see here that some of them have changed shape, and these are what we call teardrop red cells, because they sort of look a little bit like a teardrop. And that is them in a little bit of more higher power. And the cells become like that because the bone marrow becomes scarred and fibrosed, and therefore the red cells, we think, become sort of more squeezed out of the bone marrow. Again, you will see the normal red cells on this blood film, but this cell here, this cell is a red cell, but it's still got its nucleus, and that happens when the bone marrow is stressed. It can happen when people are very unwell because of infections or they've had major operations, but the bone marrow becomes stressed in myelofibrosis, so we start to see these nucleated red cells that we shouldn't really see in the peripheral blood. And occasionally, we can also see these. These are very large platelets, or actually, in this case, these are fragments of the megakaryocytes, which are the really big cells in the bone marrow that produce platelets. So we start to see these because the bone marrow is going into overdrive and making too many, and the cells are sort of fragmenting off. And then last, we also look for more primitive cells or blast cells. These are the more immature cells that the bone marrow makes. And really, we shouldn't see any of these in the blood. And in myelofibrosis, we can see them occasionally. But if we're seeing more and more and more, it is a sign that the disease is changing or becoming more accelerated, which Donal will talk a little bit about later on. So those are the sort of things in the blood that we will look at. And if we see those in the blood, combined with the history from the patient in the examination, we will then go on to do a bone marrow biopsy. So for those of you that have had a bone marrow biopsy, it involves a needle, usually into the back of the pelvis. And then we suck out some of the liquid inside. And some people are surprised to know that there's a lot of liquid inside the bone marrow. So we suck some of that out and again, spread it on a slide. And then we stain it so it looks a little bit like that. And then again, we look at that under the microscope. We can also, as well as standard stains, we can also do what we call an iron stain, where we can look at whether you're iron deficient or not. We can normally do that with simple blood tests, but we can also do that in the bone marrow. And here you can see sort of this sort of greeny, bluey material here and here, and that means that there's plenty of iron within the bone marrow. And then at higher power, we look at the cells under the microscope. So this is an example of normal bone marrow. There's a lot more cells here than what we see in the peripheral blood, because the bone marrow is the factory that makes all of the blood cells. So it's natural that we would see everything that we want to see in the bone marrow. And we like to see lots of different types of cells in the bone marrow. If we're seeing one type of cell only, then that is not normally a good thing, because there should be a variety of different cells within the bone marrow. And it takes a hematologist a very long time to train how to do this. So we don't expect you to be able to recognize any of these, but it's just an example of the process that we will be going through in the background in order to make your diagnosis. The issue with the bone marrow aspirate with the liquid sample is it's not always helpful, because in myelofibrosis, the bone marrow becomes quite scarred. So it's difficult to suck out that liquid material. So the key to making a diagnosis of myelofibrosis is the core biopsy that we will also take. So it's very similar to the aspirate. It's a different type of needle, but we will take a small section of the bone that comes out a little bit like that. So a tiny sample, normally around about 2 centimeters long, maybe 1 centimeter to 2 centimeters, and it comes out like that. We then that goes to the lab, where it's fixed, processed, decalcified, so the bone is taken out of it, in order so we can slice it really, really, really thinly, again, to look at that under the microscope. This looks a little bit like this at very low power in the normal setting. And this is what it sort of looks like at higher power. So these pink bits are the bits of bone that's holding everything together. And then these purpley bits in the middle are all of the blood cells that we are looking out for. And again, this is sort of an example of the normal blood cells that we will see under the microscope. You'll probably notice the biggest cell here, that's a megakaryocyte. Those are the cells that make platelets. So those are the easiest things to spot within the bone marrow. And those are particularly important when we're trying to diagnose myelofibrosis and myeloproliferative neoplasms. So myeloproliferative neoplasms, these megakaryocytes start to become a little bit unusual. They start to look a little bit funny. And megakaryocytes are quite solitary creatures. They don't like to be next to each other in the bone marrow. But in myeloproliferative neoplasms, they start to become next to each other in little clusters. And these are abnormal megakaryocytes that we see in myelofibrosis. And again, you can see megakaryocytes touching each other in clusters, and down here as well. So this is definitely abnormal, and hopefully you can appreciate that the cells are, instead of all being orderly, they're what we call streamed. So the cells become distorted. And over time, instead of having nice orderly bone formation, you get extra bone formation because of inflammation within the bone marrow as well. Then we look at how scarred the bone marrow is. So this is a reticulin stain. This tells us how scarred the bone marrow is. This is normal. So those of you with very eagle eyes that are looking very close to the screen, you might see the odd black line in this, which is normal. This is normal amount of reticulin. And then we try to grade the reticulin. Now, this is quite subjective, but we do try to grade the reticulin if we can. And hopefully you can see that maybe there's a few more black lines in this bone marrow. And then in myelofibrosis, you get far more of these, of this reticulin fibrosis, all of these lines that form the scar tissue. We can also do other stains to look for other types of scarring. So this is an example of collagen. This is normal. It's normal to get collagen around blood vessels. You may buy some sort of moisturizer that tells you it's got lots of collagen in to keep your skin and blood vessels healthy. But in myelofibrosis, you get excess collagen, so you get all of this blue staining here, which is not normal. So we look at the bone marrow, we look for the megakaryocytes, we look at how the bone marrow looks, we look at how much scarring there is in the bone marrow. But genetic or molecular testing is also very important because we know that mutations or variants in one of these three genes drives the underlying disease. So most people with myelofibrosis will either have a JAK2 mutation, a CALR mutation, which is the next most common, or a MPL mutation. Some people are negative for all three, but most people will have one of those mutations. And it's important to note that these mutations or variants in the genes have been acquired at some point during life. They're not new. They're not something you are born with. And having one of these mutations basically means that the bone marrow goes into overdrive and the bone marrow starts producing too many cells in an abnormal way. So how do we make the diagnosis? Well, we use the clinical details, we use what the blood looks like, we look what the bone marrow looks like, because sometimes the bone marrow can become scarred because of other reasons. So we can't just use that one thing to diagnose myelofibrosis. We need the full pattern, including the genetics. Just in conclusion, we use a lot of different factors to diagnose myelofibrosis, from the clinical details, from the symptoms that you are experiencing, from what we find on examination. We look at the blood and the bone marrow under the microscope, and we use genetics, and all of those can help us make the diagnosis of myelofibrosis. It's not one thing, but it's that pattern and all of those things integrated together that help us get to the bottom of things.
Excellent. So thank you so much, Andrew, for bringing us very nicely and clearly through quite a complex stage of investigations that help us make the diagnosis of myelofibrosis. I'm now going to move on to the second part of today's agenda, and I'd like to welcome Dr. Anna Godfrey from Cambridge, and she's going to bring us through a discussion on molecular profiling, so looking at mutations in myelofibrosis, and also how we discuss prognosis and the various prognostic scores in myelofibrosis. So thank you so much, Anna.
Thanks, Donal. Can you see my slides and can you see the correct view?
Correct view, and yes.
Super. So good afternoon, everyone. It's great to see so many people here and fantastic to be here. So I'm going to go through a little bit more about molecular testing, molecular profiling, and how we use this in clinical information in trying to judge prognosis. So how likely is it that this illness is going to cause you problems in life? So Andrew's already introduced us to the major mutations that are important in myeloproliferative neoplasms and in driving the biology of these conditions. And these are mutations in JAK2, which are the commonest, in MPL, and then in CALR. And all of these mutations, in a variety of complex ways, give rise to increased proliferation and division of the cells in the bone marrow. Normally, cells have an appropriate program of cell death, and it can interfere with those, again, contributing to too many blood cells. And it also enhances the maturation of specific types of blood cells. So, for example, the megakaryocytes that Andrew was talking about. And as he's already discussed, in myelofibrosis, for example, JAK2 is the commonest, so just over half of patients, CALR in around 1/4 to 1/3, and MPL in 5 to 10%, with a smaller proportion of people being what we call triple negative. So these are the key genes that are changed in MPN. And on the left, there's just a cartoon of some of the biochemistry that happens downstream, downstream of those mutations within the cell. But they're not the only genes that can be changed in MPN. And this cartoon has a rather more complex demonstration of some of the biochemistry in the cell. I'm not going to go through that in any detail because it's late afternoon and we'll all be snoozing into our tea. But just to say that there's a range of other things that come, again, often downstream of some of these core mutations. And all of these different molecules that I'm highlighting in this example have been involved in myeloid disease. And there are more that aren't on this list. What do these genes tend to do? So they've got a variety of functions. Some of them are what we call epigenetic modifiers. That's basically to say that they change the structure of the DNA itself in order to regulate the activity of certain genes. Some of them affect what we call splicing. So RNA is the messenger that's derived from the DNA that lives in our cell nucleus that then gives messengers downstream to the proteins to drive cell processes. And those processes are tightly regulated, and some of these proteins are involved in that. Cytokine signaling is the process of molecules that are outside the cell driving processes inside the cell through a receptor at the surface, and JAK2, CALR, and MPL are all heavily involved in that, but there are some other players within those pathways that can be changed by mutations. And then all cells also have an appropriate response to DNA damage. Often that's getting rid of the cell because we don't like to have damage to DNA, and some of these other mutations change the way that the cell responds to that DNA damage. How are these other genes different to what JAK2, CALR, and MPL do? Well, generally, we mainly find JAK2, CALR, and MPL mutations in myeloproliferative neoplasms, ET, PV, myelofibrosis, or closely related conditions. These other genetic changes that I'm talking about are often found in a very broad range of other myeloid conditions, not just MPN. And that's probably because the JAK2, the CALR and the MPL really drive what we call the phenotype of an MPN. So the things that we think of as really characteristic for an MPN, in PV, for example, the high hemoglobin, in often all three conditions, the high platelet count, and ultimately the fibrosis within the marrow. Many of these other genes that we're talking about, when they're mutated, are thought to alter at a more basic level, how fit is that cell? So of all the cells in your bone marrow, and there are many different stem cells that divide to give rise to more mature cells, some of them will be fitter than others. And if these mutations make that cell fitter, then that cell is likely to survive more than others, divide, and ultimately go on to, it allows it to go on to cause problems. Lastly, most patients who have an MPN, not all, but most, have either JAK2, CALR, or MPL. You don't tend to have more than one of those. Generally, one is enough to cause an MPN. Just occasionally, people have two. They're normally in different cells. Whereas these other mutations that we're discussing are often found in combination with JAK2, CALR, or MPL, and in combination with each other. And we're more likely to find these additional mutations in myelofibrosis, and some of them in patients who develop acute leukemia. So how common is it to find these additional genetic changes? So I'm showing you here some results from a study that some colleagues of mine and as part of an international collaboration did around about 5 years ago. And they looked at over 2,000 patients who had some kind of MPN. They didn't all have myelofibrosis, but in that whole cohort, around 45% only had mutations in JAK2, CALR, and MPL. Myelofibrosis is probably a smaller group within that whole cohort, and that it's more common in myelofibrosis than 45% to have, sorry, more common than the 55% to have additional things. 55% in this study had something else. And if you look at this graph, you can see that the commonest mutations that we found were in JAK2 and CALR. MPL is slightly less common, so just to show you the y-axis here, this is 5%, whereas we're finding JAK2 in over 60%. But then along the x-axis here, you can see this whole range of other genes and chromosomal abnormalities that were all affecting a smaller proportion of patients who had an MPN. How do we actually identify these other genetic changes? So you may hear your clinicians talking about a myeloid gene panel. Sometimes we refer to it as a next generation sequencing panel. And that's just because this is a relatively new technology. I'm not going to go through all this biochemistry either, but basically the key thing about this new technology is that it enables us to look not just at JAK2, for example, but to look at multiple different genes in one test that's done on DNA from either blood or bone marrow, typically in this situation. When we do this kind of test, we're looking for what we call variants. A variance just means a change in the DNA from the normal sequence that we think is contributing to disease. So that's what we mean by something that's pathogenic. And just by the by, sometimes when we do these tests, we also find changes in the DNA where we're not actually sure whether they're really contributing to the disease or not. We call those variants of uncertain significance, and we tend to not use those so strongly in our practice. So up the top here, this is just an example of the panel that we have in our local genomics laboratory. And if we go to ask a myeloid gene panel in someone with myelofibrosis, we'll look for mutations in all of these different individual genes. In addition, because genes at a much bigger scale are organized into chromosomes, we also often do a technique that looks at the whole chromosome rather than these individual genes. And what we're really doing there is to say it's not just one little change within that gene that's happened, but actually we might have lost a whole chromosome or gained a whole chromosome or part of a chromosome that we can see at a much bigger scale. So on the left hand here, you can see what we call a karyotype. That basically means looking at the chromosomes. You culture the cell in a specific way and then burst it open, and then the chromosomes don't all line each other up like that, but we have some very skilled scientists who can put them all together and look for patterns in them. And we do find changes in karyotype in around 45% of patients with myelofibrosis. We sometimes use an alternative technique called a SNP array, just in case you've heard the different language. But again, that's there to look for changes in number of large regions of chromosomes. So how does this information actually help us? So first of all, it can actually be quite useful in patients who we think have an MPN, but we can't find a mutation in JAK2, CALR or MPL. And that would include, for example, those triple negative patients that we were talking about, where we think this is myelofibrosis, but we haven't seen one of those common mutations. And we would interpret that information very much in conjunction with the bone marrow biopsy that we've done. What's really helpful, and what I'm going to go on to talk about a little bit more about, is using this information in prognosis. So information about these additional mutations and changes in the cytogenetics can give us information about the kind of risk of disease progression, or how likely it is in large cohorts of patients that, that there will be changes in survival as a consequence of this disease. And this is really important, particularly if we're considering a treatment that has some risk. So the classic one is stem cell transplantation. Transplantation does have considerable risks, and we need to balance up how likely is it that the disease is going to cause problems versus the risks of the transplant. And in the future, we'd like to think that we're able to use some of this information in more personalized therapy according to a patient's mutation profile. We're not quite there yet, but there are exciting developments that might tell us that we're going there in future. So a little bit more about prognosis. There are various different prognostic scores that we use in myelofibrosis, and we can never all remember the details, so we have to look them up at the time. So no one's expected to remember this, but one of the commonest is the DIPS score. This is the Dynamic International Prognostic Scoring System, which uses a number of clinical factors like your age, do you have significant sweats or weight loss, and then some features of the blood count. Each of those is given some points, and then you tot up your points to give you a risk score, which might be low, intermediate, 1, 2, or high. And then what this kind of plot shows is the average survival of these kind of different groups of patients. So for example, if you look at this low risk group, if you're in the low risk category, then the chances of survival are around 50% at kind of 11 or 12 years. So we'd say the median survival is 11 or 12 years. The DIP score is largely based on clinical parameters. We can use it any time after diagnosis, which is really helpful. And it's often the score that's been used to select groups of patients who are going to go into a clinical trial of a new therapy. So for example, the JAK2 inhibitors. And what that then means as a consequence is that often those therapies are actually approved for a particular risk group of patients on whom the study was done. So if the studies were done in patients who had intermediate 2+ disease, then that's who the drug may eventually be approved for. Other prognostic scoring systems that are newer are now getting a little bit more complicated. So this is one called the MIPS 70+ version 2. It's got at least one predecessor, and you can see here that in this scoring system we've also got genomic information. So we've got, is there a type 1 CALR mutation? Are there high molecular risk mutations? And these are the ones that were defined in this particular prognostic scoring system. Are there worrying abnormalities on the karyotype? And we add all of these points up again to give us a score, and that tells us which category the person falls into, and again a median survival with a kind of average survival at 10 years. There's a score called MySec-PM, which I'm just mentioning briefly to mention that this is a score that we use specifically for patients who have post-ET and post-PV myelofibrosis, as opposed to primary myelofibrosis, because that's specifically what it was validated for. Again, a slightly different criteria, slightly different risk groups. And then finally, there is what we call this personalized prognostic calculator, which was developed at the Sanger Institute in Cambridge, and it's now available on this website, where you put in all of the clinical and genomic information that you have, and it actually it gives you some kind of prediction of the individualized risk of various different outcomes. So I'll just show you some examples of that. These are 2 real patients from our service. The first one, a 37-year-old patient who presented with primary myelofibrosis. She had a type 1 CALR mutation and was reasonably anemic. So the lower limit of normal hemoglobin for a woman is around 115 in our laboratory. And she didn't have any immature cells on her blood film. She didn't have any particular symptoms. Her myeloid gene panel didn't show anything additional to the CALR mutation. So on the DIP score, she got 2 points, and we would call her intermediate 1. The second patient was 59, had a JAK2 mutation rather than CALR. Again, was anemic, mildly so, more mildly so, did have some immature cells, these blasts in the blood, and had some sweats and weight loss. And on his myeloid gene panel, he had a TP53 mutation and an ASXL1 mutation, and they're both considered less favourable in terms of risk. So the DIPS score, actually, he only had one additional point, and this did make him intermediate too. But when we looked at the personalised prognostic calculator, the results for these patients were very different. So in this first patient, you can see, for example, the likelihood of them being alive at 5 years is 93%, with a risk of acute myeloid leukemia of only 2%, as compared to this patient, whose chances of being alive at 5 years were much reduced, more like 52%, and a risk of AML at 5 years of 28%. So this patient on the right-hand side was the one who we recommended a stem cell transplant for. In fact, there are even more prognostic scores than this. I'm not going to go into them all, but just to understand that different scores can sometimes give us slightly different results. So we'll often calculate several together, and that should give us a more balanced idea of the risk from the disease. But I think it's really important to emphasize that none of these results should be seen as a personalized life expectancy. None of us can do that. It can't give you an expectation of what you will get from your disease. They're very much averages from big cohorts of patients who have had similar findings. What we can do is use this information to weigh up the risks of the disease against the potential risks of treatment, typically transplant, which helps us to have a more informed discussion about what's a good idea to go for. So I'll finish there just to summarize that this comprehensive molecular testing can tell us more about the biology of myelofibrosis. It certainly adds some information about the long-term risk. It's really important to remember that at the exact time course of the disease and the outcomes can't be predicted for one individual, but using these scores can help us to weigh up the risks of treatment with the risks from the disease, and that we do hope in future understanding some of this variation in genetics will help us to develop some personalised therapy, even if we're not quite there yet. I'll stop there.
Thank you so much, Anna, for bringing us so nicely through a complex area of looking at the mutations and all the different prognostic scores that we have to balance. And just to remind everyone, if we have any questions that haven't been submitted already, just to pop them into the chat and we'll try to address them in the Q&A session. Thank you so much. So it's a pleasure to invite my friend and colleague, Dr. Alesia Kahn from Leeds. And she's going to bring us through a big topic in 15 minutes, which is treatment options for myelofibrosis. Thanks so much, Alesia.
Thank you. So hello, thank you for the kind introduction and also the invitation to speak. It's a pleasure to be here. Today I will talk to you about the treatment of myelofibrosis. So first of all, I've got a very busy slide for you. This is from the most recent management guidelines of myelofibrosis, which were published in the British Journal of Haematology in January this year by a group of MPN specialists, including all the people talking today. And we evaluate all the evidence, available evidence, and design guidelines which are to be used throughout the country. And these really help us to guide how best to treat everybody. And this looks like a really busy slide, and you'll be thinking, goodness, which treatment do I have and when, doctor? So I will break this down and go through each bit individually to give you an understanding of how we decide which treatment is best for you. So first of all, we really need to consider, why should we treat and when? Because a lot of things will be going on when you're first diagnosed or as you go on in your investigation pathway. And the first thing to mention, we've touched on already today, is you may be having some symptoms of splenomegaly. So when your spleen gets big due to the disease, this may make you feel full early, so you can't eat big meals, and that in turn can cause weight loss. You may have what we call constitutional symptoms. So there's a night sweats where you're drenched in the night or having fevers. And if you become anemic, that will make you feel very tired. You may have had a blood clot, which can cause a number of different problems, and you may require treatment. Well, you will require treatment for that. And the other thing is that because the bone marrow doesn't work at its full capacity, you're unable to make all those white blood cells that Andrew told you about. So it's not so easy to fight off infections. You may get infections. And you'll know from going to a busy clinic, there are always, you know, a lot of things to talk about in the clinic. But a really, really important thing to think about is knowing your MPN 10 score. So this score, I'm sure most of you already know about this, and there are different ways to record it. So there are a number of questions which are really, really important to answer and add up the score. And knowing the score, whether you're very symptomatic, can really help decide whether it's time to start treatment. And there is a booklet which can be given out from one of the drug companies. And there is also now, very excitingly, there is an app which Patrick Carrington designed in conjunction with MPN Voice, and it is available to register for on the MPN Voice website. And this is really handy to be able to put your MPN 10 scores in. And if they're high or going up, you can discuss this with your consultant, or if you started treatment, you may see them go down. So it's really useful to take that to clinic and discuss that with your consultant, because you may be feeling overwhelmed with all the different things that you have to deal with. Like, you might want to exercise, but you're not sure whether you should. You might feel really exhausted in the day and you're not sure if you should nap. You might feel overwhelmed and emotional and you're not sure where you can get help from. And you're wondering how your spleen can feel more comfortable. So, and also there can be other things going on, like the GP might be telling you about that your blood pressure is high and your cholesterol is high, and you're not really sure if you should be taking additional medications. So we can help with all these things. We can talk to you about different types of exercise, and I know some places have really useful physio videos. There's ways you can track your steps while you're walking. Some people really enjoy the fact that if they start ruxolitinib, they feel like they can go swimming again because their skin is not itching so much. There's some advice that we can give about napping. So you can take a nap if you feel tired, but not too long, and do it early in the day so it doesn't affect your night's sleep. And if you're feeling emotional and overwhelmed, there's so much support available, and your friends and family will want to help you. Some people are reluctant to burden friends and family, but in most cases, they're really happy to help you. And there's lots of charities available, including the MPN Voice body system. And you know, some people also get referred to psychology for further input. There are lots of hospitals have Maggie's Centre, which can give practical advice and help with filling out various forms. A JAK inhibitor may be started if the spleen is very big and uncomfortable, and that may help the spleen discomfort. And we are learning now that JAK mutation is an independent risk factor for cardiovascular disease. And even though we're haematologists, we need to be looking at all different aspects of health and controlling blood pressure and cholesterol. And we're working more with GPs and cardiologists to optimize all these factors and keep you healthy and well for as long as we can. So now just moving on to all about whether we start the treatment really just depends on the risk scores, which Dr. Godfrey went through. So we will do the risk score, and from the BSH guidelines, we will decide if based on the risk score for the DIPS plus, if the risk score is low or intermediate 1, you may have absolutely no symptoms at all and your spleen may not be big. And sometimes it's good then to have a period of a watchful monitoring. Some people feel like a little bit anxious about that they feel they should be on treatment, but sometimes the treatments have side effects, and this risk score is designed to make sure that you have that period and we can watch closely. If, however, you have symptoms like splenomegaly or the sweats or weight loss or fever, then we may consider treatment options. And in this group, the really NICE does not give the option for using JAK inhibitors such as ruxolitinib, but we do have a few other options for treatment. For example, interferon, although I'm sure you're all aware of them, or you might be aware of, there is an international shortage of interferon, but that still is an option. for controlling blood counts and sometimes can reduce the spleen. There's also hydroxycarbamide, which are capsules, which may again control blood counts if they're high, and sometimes has some effect on the spleen size. And the other option is clinical trials. So for example, we recently finished recruiting to a clinical trial called Fedora, which was using a JAK inhibitor and an interferon. The JAK inhibitor was called fedratinib. And this was if you were intermediate 1 and you had splenomegaly of more than 5 finger breadths below the ribs, then you may be eligible for that trial. So that's one way where you would be treated with a JAK inhibitor if you were intermediate risk score. But those clinical trials, you know, they're variably open, and then when they've finished recruiting, they will be closed. So Fedora has closed now, but some people might still be on those treatments. Then if your risk score is intermediate 2 or high, then first of all, we'll decide, assess you and see if you're transplant eligible. So that means if you're on the younger side and fit, so no lung disease or heart disease. There's a whole process to go through for assessing fitness and transplant eligibility. If you are transplant eligible and the spleen is big, then it really needs to be reduced before the transplant can go ahead. So a JAK inhibitor will be given until the spleen is as small as it can be. Otherwise, when you give the stem cells from the donor, they all get lost in the spleen and they don't go into the bone marrow where we need them to go. If the score is intermediate 2 and high risk and you are not suitable for a transplant, because transplant is very has a lot of risks associated, then we will consider other treatment options. And this is the majority of patients go down this route. So first of all, there are a number of different JAK inhibitors, which I'll go through shortly. And if you didn't stop responding to one JAK inhibitor, then there are other JAK inhibitors to try. There's also the option of clinical trials. And for every different stage, we'll be looking to support your care. So there are different treatment adjuncts that we'll use along the way. And these include blood transfusion if the hemoglobin is low. And this doesn't have to be that you're then on regular transfusion. Sometimes regular transfusion is required or just sometimes intermittent. If you've had a previous thrombosis, then you will need a blood thinning medicine. And this has to be balanced carefully with the platelet count. And then there are different medications which can help anemia, which are erythropoietin is a hormone injection which can stimulate the red cells. And there's an old drug called danazol, which is a hormone, and that can improve the hemoglobin in some people. We would always advise the seasonal vaccinations, and before having a JAK inhibitor, we would advise the Shingrix vaccination, which is a non-live version of the shingles vaccination, because we know that JAK inhibitors reactivate shingles. And we'll always be looking to help you with nutrition to make sure that you're feeling as well as possible. So just going on to the JAK inhibitors, the first JAK inhibitor was ruxolitinib. It was approved in 2016 by NICE, and it's really effective for splenomegaly and symptoms. And we are now seeing that in real world data and some of the pooled data from the trial that it can improve survival. It can cause anemia, which usually lasts for about 8 weeks, and then the hemoglobin comes up to the baseline. And we can support through that period of anemia with some of the adjuncts I talked about, or sometimes we will consider an alternative JAK inhibitor. And we can give ruxolitinib as long as the platelets are above 50, and if they're below 50, we'll be considering other JAK inhibitors. And I've talked about the risk of shingles, and there's also a risk of TB and hepatitis B reactivation, so we'll be monitoring those things and checking that. And this just shows in the Comfort 2 trial, which looked at giving ruxolitinib versus the best available therapy, which was things like hydroxycarbamide. You can see the amount in yellow is the amount that the spleen reduced when on ruxolitinib, and that is much larger than the amount in blue, which is the amount the spleen reduced on the best available therapy. So it's very good for reducing spleen size. Momelotinib is quite a new JAK inhibitor, which was only approved in September 2023. it inhibits not only JAK, but ACVR, which leads to the inhibition of liver hepcidin, which is a hormone, and that leads to iron immobilization and the production of new red blood cells. And we really are seeing that in clinical practice, which is great to have another alternative option. It might not reduce the spleen volume quite as much, but it definitely improves anemia. It does reduce the spleen to an extent, and we can give it, well, as long as the platelets are above 25, so slightly lower platelet threshold. So just a quick case for that, to look at Momelotinib. This is a real case of an 89-year-old lady. She lived completely independently with no help or family. She was on ruxolitinib and erythropoietin, but then started to need blood transfusion every 2 to 3 weeks. So this was a lot for her. And so I switched her to Momelotinib, and initially she had some GI upset, so I reduced the dose. And I did advise her to take this last thing at night just before she goes to sleep. So she's lying down, because you can sometimes get a bit of dizziness and unsteadiness when you start taking it. She was absolutely fine. And 2 months later, she had no transfusions at all. And she was leaning down on the erythropoietin, and the hemoglobin was the best it's been for months. There's another JAK inhibitor called fedratinib, which is a selective JAK2 inhibitor for intermediate 2 or high risk myelofibrosis when there are symptoms and splenomegaly. And this is to be used after ruxolitinib. It can be given as long as the platelets are above 50. There are some side effects, like there was in the trials some confusion. So we realized that that was because the thiamine level was low. So now we always check the thiamine level and prescribe thiamine. And as I mentioned before, it was used in the FEDORA trial along with a type of interferon, the road-regulated interferon. And NICE are re-evaluating its use, and they'll update us soon. There are some clinical trials which Don might tell us more about. There's a PROMISE trial, which is using an agent with ruxolitinib for patients who have ongoing splenomegaly despite ruxolitinib. That's a phase 1 trial, so it means the agent hasn't been used in human participants before. There's Pacifica trial, which is another JAK inhibitor called pacritinib, compared to best available therapy for intermediate 1 to high risk myelofibrosis patients. And this can be used when the platelets are lower, less than 50. There are a couple of other trials. So there's eltriticept, which is an injection which is a bit similar to erythropoietin, used with ruxolitinib or single agent, and it can be given for the treatment of myelofibrosis when the cytopenias are present. So that means they're low counts. And now we're looking at more targeted therapy, for example, the CALR specific agent. So there is an antibody. So that means it binds to CALR to try to inactivate it. And that's for use in myelofibrosis with CALR mutation and splenomegaly. And that's a phase 1 trial as well. And this is just from Dr. McLornan, really highlighting that there are really a lot of trials going on, and we're all excited to see the results of these. So thank you very much.
Thank you so much, Alesia, for bringing us through all the current and future treatments. I'm sure there'll be lots of questions on that in the questions. And can I just check that people can see my slides okay?
Yep.
Yes.
Yeah,
Thanks so
we
much.
can see them. Thanks, Donal.
Thank you so much. So over the next 5 to 10 minutes, I just really want to talk about some key aspects of accelerated phase myelofibrosis and transformation to leukemia. So I think it's really important before I start this session to say that everyone's journey, as I don't need to tell this group, with myelofibrosis is different. And we can have various ways of prognosticating risks, like Anna has discussed, and part of those risk profiles can inform some of the aspects of potentially developing accelerated or blastic phase disease, but none of those scores that we currently have are clever enough to tell us exactly when and if and in who it will happen. So what do we mean about accelerated and blastic phase disease? So Andrew showed us a blast cell, so a very early cell that in a non-myelofibrotic bone marrow picture, we don't normally find them in the peripheral blood. But when we have scar tissue in the blood, we often see a small percentage of these blasts at a very, very low level start to circulate in the bloodstream. And we enumerate them, so simply count them. We can do it by manually counting them down the microscope, or we have other ways of looking at how mature the cells are. It's called flow cytometry, and we can enumerate them in a blood or bone marrow sample. But really, we percentage as the blast percentage by looking and saying if they're between 10 to 19%, it's accelerated phase disease. And if they're persistently, and it's important to remember, persistently above 20%, that's moving into the range of an acute leukemia. Now, this is a busy slide, and my colleagues have very nicely talked about loads of these aspects before, but just a few key points. We know that when we look across the MPN spectrum, we have to look at the patient, what the chromosomes, so what the machinery inside the cell is telling the cell to do, what the genes, so if there's mutations, what's driving the myelofibrosis, and it's usually in the front seat, so genes like JAK2, calreticulin, and MPL. But at any point in the disease course, or even when you're diagnosed, there can be mutations in the back seat. And some of those are what we call high risk, and they can mean the chance of developing accelerated phase or higher phase disease is actually higher. Other things that are important, we know that the risk scores that Anna discussed, if someone has a high DIPS plus score or a high MIPS score, they're at a higher risk on average basis of developing more aggressive disease than someone who is very early as regards having a low risk disease. And in the past, we know that some of the treatments that were used 20, 30 years ago may have actually contributed in part, but not caused, this higher risk of developing accelerated phase disease. Now, this is a busy slide, but really what I'm trying to show here is that there are a number of different routes that the myelofibrosis causing stem cell can take. So for the vast, vast majority of people, it stays in chronic phase. So there's not more than 10% of these blast cells. But in some patients, we know that the mutations take dominance within the bone marrow. So the normal stem cells in the background can't do their normal job. And when there's mutations present, it predisposes those cells to develop other mutations. And sometimes those other mutations stop the normal cell cycle. So the normal day-to-day activity of the cell is disrupted. The immune system can often keep that in check, but sometimes it breaks through the effect of the immune system. We start to see more early cells in the blood, accelerated phase disease, and in some patients, leukemia. It is rare to go from chronic phase direct to a leukemia. It most commonly goes from chronic phase through to accelerated, through to a leukemic phase in some patients. Anna has already discussed the mutations that we call high risk. And it's very important to remember, even if your doctor talks about these high molecular risk mutations, there are many, many people who are doing well on JAK inhibitors who have these mutations, but still remain in chronic phase, but a small proportion will accelerate or develop a leukemia. Anna has also shown this prognostic model, and I think this sort of model that the team from Cambridge developed is super helpful at looking at potentially long-term prognosis. But it's super important to remember that these are simply models, and we're looking at averages. So we try to combine all of these different prognostic scores that we have. So in summary for transformation, I think we have no biomarkers or specific characteristics that tell us with 100% certainty when transformation will occur. But over the last few decades, we're getting better at trying to impart better information to you as our patient. We look at clinical factors, what blood counts are doing, what's happening with mutations. Two patients can have exactly the same mutations, exactly the same phase of the disease, and one may accelerate and one may not. So we still have a lot to learn. But we know that this risk causes anxiety, both for you as a patient and also for us as your clinician. So what do? We monitor you very closely. We monitor your blood counts. We look at your blood film under the microscope like Andrew showed us, and we enumerate what's happening in these blasts. We look at what's happening symptoms and spleens. Dynamically, we should intermittently look at what's happening chromosomes. So are they changing? Are there new mutations happening? And if we see any of these things changing, we may discuss with you about repeating a bone marrow test. So I don't need to tell this group about the bone marrows. I know they're never nice to have done, but it's an important way for us as your clinical team to understand what's happening within the bone marrow space. And are we seeing increased blasts, importantly, within that space as well? So the treatment approaches are very specific to the patient. And I'll talk about those in my last minute, but I think up front, it's really important for all patients to know, we want to know about what does the patient want? How old is the patient? So the treatments are very different for someone in their 30s or 40s and someone who's in their 8th or 9th decade. How well the patient is. So do they have other health problems that may limit some of the treatments we can give? We want to sometimes, if we're thinking about more intensive treatments, look at heart function, kidney function, breathing tests, and also what support the patient may have. Now, this is a super busy slide that comes from the paper that we published as a group within the UK. But when someone is diagnosed with an accelerated or a leukemia arising after myelofibrosis, we look at all those patient-specific factors. We look at the disease stage. And then the most important question up front is someone eligible for a transplant? And if not, what are the treatment options? So in brief, in the UK currently, someone has to be quite fit to undergo a transplant. It's a very intensive procedure with risks that we have to balance against other medical therapies that we have available. If someone has accelerated or leukemia after myelofibrosis, then we often give chemotherapy, sometimes as an inpatient, sometimes as an outpatient, and try to get that patient to transplant if they have a donor and if everything is suitable to have a transplant as an option. If not, we look at disease control. We can't cure leukemia after myelofibrosis without a transplant, but we can certainly have ways to control it. And those are often drugs like azacitidine. So it's an injection of chemotherapy given below the skin, often in the tummy, for 7 days, every 28 days. And we often give it in conjunction with drugs like ruxolitinib. And this was a trial supported by the MPN Voice team called PHASAR that explored the potential benefits of that combination. Now, again, a busy slide, but the landscape for treatments for leukemia, if someone develops leukemia after myelofibrosis, is changed quite considerably. Even in the last 10 years, we're seeing a lot of new drugs coming into the field to try to get better responses for leukemia. And that includes leukemia that can happen after myelofibrosis. And just to let the audience know, and I know the MPN Voice team are aware of this, myself, Claire Harrison, Steve Naber, Adam, and the whole group that are here today, we're trying to set up a trial run across the UK looking at Momelotinib in conjunction with other drugs to try to get better outcomes for patients who have accelerated or aggressive myelofibrosis or who develop leukemia after myelofibrosis. So I'd like to stop there and thank you so much for listening. And I'm going to stop sharing my screen. And it gives me great pleasure to welcome Don, who is a patient with myelofibrosis, and he has very kindly agreed to chat to us over the next 8 to 10 minutes about his experience of being on clinical trials for myelofibrosis. Thank you so much, Don, and welcome.
Hello, everybody. As has been said, my name is Don Glossop. I'm 75 years old, and I've suffered from MPNs for over 20 years. I was first diagnosed with polycythemia back in 2003 after a routine blood test. Following the test, I received a call on my mobile from a GP who asked me to go in and see him. I asked if he could tell me over the phone what it was about, but he was quite evasive. I jokingly asked if it was serious or life-threatening, but again, he avoided the question and asked me to go in and see him at his surgery. When I saw him, he told me that the blood test results showed that I'd got polycythemia, an abnormal blood condition, and he referred me to a specialist haematology consultant. When I saw the consultant, he explained what polycythemia was and reassured me that it was something you died with and not died of, which again was quite reassuring. I was put on a drug called hydroxycarbamide, and for the next 13 years or so, I saw a haematology consultant at St James's Hospital in Leeds, roughly every 6 months, and remained symptom-free, living a relatively normal life. In late 2016, I began to feel breathless when walking uphill. And I also had occasional pain and discomfort around my midriff, and began to have night sweats and itching. I mentioned this to my consultant, who arranged for me to have a bone marrow aspirate. As has been said, not a very pleasant procedure, but essential to the process, I guess. I also had a scan of my spleen, which showed it to be enlarged, and at that time, I was informed that my disease had progressed to myelofibrosis. Not a medical person at all. I was told about JAK2 and mutation. So I was prescribed a relatively new drug, ruxolitinib, and quite quickly the night sweats and itching disappeared. And other than occasional discomfort around midriff caused by the enlarged spleen, I was pretty much symptom-free again. At this stage, I began to have more regular visits with the clinic at St James's Haematology Department, roughly every 3 months. Myelofibrosis, I understand, can affect blood counts, and over the years following my diagnosis, my blood levels gradually fell. In October 2021, I had my first blood transfusion. And since then, I've received regular transfusions, roughly every 4 weeks, 1 or 2 packs, if that's the right term, based on my hemoglobin levels. The measure for me determining whether I had a transfusion was if my hemoglobin levels fell below 80, although this benchmark has recently been increased by the doctors to 100, which means recently I've been having transfusions every 2 weeks. Other than the fatigue, which affects my mobility, health-wise, I'm doing okay, and obviously assume this continues for years to come. I have been informed about trials, and I've taken part in 2. The first one, unfortunately, I had to come off because my blood counts fell a little bit below the required level. In May this year, I began another trial called Keros, I think you pronounce it, which is a potential treatment for anemia in people with blood conditions like polycythemia and myelofibrosis. The trial lasts around 12 months and involves monthly injections to hopefully boost blood levels and avoid the need for further transfusions. Obviously, it's early days, but so far so good. And that's basically about it, I think.
Dawn, thank you so much. Do you mind if I ask you a question before we jump on to the next bit? So thank you for giving such a clear history and just your experience of the trials. I mean, it's interesting for me. What did you think when you were handed all the information about trials like the Keros trial? Because it's a lot to take on board, isn't it?
I don't think it is. I don't think it is really. I got provided with a pack of information. They explained all about what the trial was, and whilst I didn't really understand it, it was a good explanation and not overcomplicated or medically based, so it was easy to follow. And I think at that stage it's a question of, obviously, does it will it help my condition? Will it help the research and all the rest of it? And so far so good. I've 1 or 2 issues having the injections and things, but I think it's a small price to pay really for potentially what might lead to something better in the future, just as I benefited from ruxolitinib and the rest.
Dawn, thank you so much. I think it's a perfect summary of the trial experience. And I think there's a question, if that's okay, Dawn, before I switch
Yeah,
across from
of course.
one of the team, just about what was the name of the last trial? Are you currently in Kairos, or have you changed to another trial?
No, I'm currently in Kairos, and it's a 12-month trial.
Perfect. So that's looking at injection to try to improve the maturation of the red blood cells.
Yeah.
And I know there's some evidence that can also help with symptoms and spleen size as well. Dawn, thank you so much for bringing us through that. That was excellent. Thank you so much for sharing your experience.
No problem at all. Thank you.
And if you stay on the call with us, it'd be great, because we're going to switch across to the question and answer session. And thank you so much to everyone for submitting their questions. Maybe I'll start with just a few questions just about the myelofibrosis, Andrew, and the diagnosis, if that's okay. So there's a number of questions on the same theme, just about, are there other blood conditions that can change into myelofibrosis? And also, what are the more common symptoms associated with myelofibrosis? And I'll direct that to Andrew, if that's okay.
Yeah, so myelofibrosis we tend to call it primary myelofibrosis if people are diagnosed with that from the start. And the symptoms that people can experience, of which they may experience none, it might be picked up because you have an ultrasound scan which shows you've got a big spleen, and the ultrasound scan's been done for another reason. Or you might have a CT scan for a reason, and the bone texture on the scans looks a little bit abnormal. So sometimes you can come in from that route, or you might have a routine blood test and you're anemic. But the symptoms that people might experience include, as Alesia mentioned, sort of weight loss, night sweats, and as Don mentioned as well, he had sort of that uncomfortable feeling around the stomach, which I presume was probably related to a big spleen. So those are the sort of symptoms that people can get, including fatigue as well. And then diagnosing myelofibrosis, like I say, can either happen because that's the thing you diagnose it from the start, or people can start with having essential thrombocythemia or polycythemia vera, and then change into having myelofibrosis over a period of time. So that's generally how it happens.
Thanks so much, Andrew. And then a few questions, Anna, if that's okay for you. There's a question about someone has just newly been diagnosed with myelofibrosis, and is it typical to see fluctuations in platelet count during someone's disease course with myelofibrosis?
Yeah, so people often ask this. Everyone's platelet count fluctuates up and down. So my platelet count will go up if I've got an infection, or in people who have bleeding, have operation, if you're deficient in iron. There's lots of reasons why platelet counts go up normally, and that's because platelets are generated as part of a stress response. So that's the first thing. And then the other thing is, in myelofibrosis, several things can affect the platelet count that are part of the disease, and they can affect it in different ways. So sometimes people in the earlier phases of the disease can have the higher platelet counts. Sometimes as the spleen enlarges, that means the platelet count goes down, because at any one time around a third of your platelets are in your spleen. But sometimes it just seems a bit random, and things do go up and down, and we don't have an explanation. So don't try not to read too much into it. There is a bit of natural fluctuation. If things are going progressively in a particular direction, then obviously we may want to have a look at why.
Thanks so much, Anna. And then just one other question, if that's okay. There's a few questions themed around if someone has the early stages of myelofibrosis, so lower risk or intermediate risk 1. Often patients are on observation or sometimes on aspirin. And the question is just about, is there any suggestion of earlier use of targeted therapies, or why do we delay those to the higher stages of the prognostic groups of the disease?
Yeah, so I think you use medications in medicine for a few reasons, don't you? So one is, if you had a medication that we knew would reverse the underlying disease, then we try to get everybody on it, particularly if it had no side effects. But in real life, that's unfortunately not true of many of our medications. So one of the reasons we reserve, or we tend to employ the JAK inhibitors in the higher risk groups, is first of all because that's where the trials were. That's where the trials showed benefit, and in fact, because that's where the trials showed the most benefit, that's where the drugs are funded. Lots of people with low risk disease actually don't have too much in the way of symptoms, or at least not symptoms that would warrant the potential side effects of a therapy. So exactly as Donal said, sometimes we identify myelofibrosis essentially as an incidental finding because you had an ultrasound for another reason or you had a blood count for another reason, but people are actually relatively well. And in that situation, don't let us make you feel any different by giving you treatments that you don't need. I think there's a group of people who are perhaps in the intermediate 1 risk group who have a slightly trickier time, perhaps a big spleen that is actually causing some symptoms, but no other kind of risk factors on the DIPS score. And that's a situation where sometimes if you do have access to a clinical trial, sometimes there are some clinical trials that will recruit people at intermediate 1 level that mean you have access to drugs that you wouldn't necessarily otherwise have in the general healthcare setting. But I don't think there's any right or wrong, and there's no right or wrong because every patient is different. You know, you can have 2 people with intermediate 1 risk disease who are completely different in terms of their symptoms and what they really need. So it's really down to that individual need, I think.
Thanks so much, Anna. Thank you. Maybe Alesia, if I could move on to a few questions just about treatment, would that be okay? So one of the questions was about Momelotinib. So as we know, we've recently had nice approval for Momelotinib in the UK. And prior to that, we had a compassionate access scheme, and many of us were involved in the trials. But the question, Alesia, just simply concerns, what are the most common side effects that a patient who's maybe newly starting on Momelotinib may experience?
So Momelotinib can cause a little bit of dizziness and lightheadedness when you first start. So we have given some advice to patients about getting it already at the bedside with a glass of water and then taking it just before bed so that you're lying down and you won't feel those effects of lightheadedness and you're less likely to fall over. So we did have a few patients who noticed they had a few falls at the beginning associated with a little bit of drop in blood pressure. And that seems to settle down over the first 2 to 3 weeks, which is good. And taking it last thing at night can help prevent any falls. And the other thing is people sometimes describe a little bit of nausea and loose stools, which again is quite self-limiting and settles down over the first 3 weeks. Those are the main side effects, and then there's obviously the similar things to ruxolitinib, such as slight increased risk of infection.
Thanks so much, Alesia. And maybe another question, and there's a few questions actually on Momelotinib, which I think we know because we're getting used to using the drug and patients are getting it prescribed often for the first time, is do we have any feel from global experience of the Momelotinib trials, how long patients may continue to experience a benefit whilst on the drug? And I know that's a very broad question because everyone's very different on how long the JAK inhibitor benefit will last.
Yes, I guess everybody is different, and they showed in the trials that there should be some benefit after the first 24 weeks. So reduction in the spleen and symptom benefit, and also the improvement of hemoglobin. And we're gathering the real world data to show that that can definitely last, you know, for that period of time. But everybody responds differently, and you'll be monitored carefully in the clinic.
Thanks. And maybe I'll take the next question. Very relevant question is someone asked about if you have myelofibrosis. As you know, in the UK currently, we're allowed to use Momelotinib for people who have disease-related, so myelofibrosis-related splenomegaly or symptoms, but they have to be anemic, so a hemoglobin less than 100. And that's how it's reimbursed to the hospital systems. And they've asked about using it in patients who've got high platelets. So it's fine to use with a high platelet count. You'll be monitored very closely, often with 2 weekly blood tests after you start the Momelotinib. And as Alesia presented, one of the real benefits from Momelotinib is we can safely use it down to patients who have a much lower platelet count. So a platelet count has to be 25 or above, but you can still maintain a good dose of the Momelotinib down to a platelet count of 25. However, to be clear, when we're dealing with those sort of super low platelet counts, often we need to monitor the platelet count much closer than even 2 weekly. One thing, as Alesia said, we're collecting all of the data nationally across the UK for patients on Momelotinib to assess their response, to look at things like how quickly the spleen's responding, what's happening, blood counts. And interestingly, in some people who've had maybe had a normal platelet count, we're seeing that the platelet count can rise quite high. So we're watching that. So some people, paradoxically, when they go on to Momelotinib, may need some additional treatment, though that would be rare, to bring the platelet count down. But it's something we're trying to look at on a national level. So that was a really great question. We have 10 minutes left for questions. Maybe Alesia, sorry to keep you on the hot seat, but the next bit I'm going to do is transplant. So maybe just one really relevant question about interferon. So you've talked about, we know we're facing a shortage, and we've seen the different approaches we're all trying to bring to our patients about managing that shortage. There's been a recent MPN Voice vlog looking at this, talking to Claire with Nona, which was super helpful, released this week. But I think, is there any evidence if we're using drugs like Pegasus or Besremi and how that affect maybe disease transformation or the degree of scar tissue within the bone marrow?
Mm-hmm. Thank you. So there have been some studies looking at this, but these are small studies. So there was quite an old study from about 2015. They looked at 12 patients and showed that interferon reduces the scarring, the fibrosis in the marrow. But 12 patients is too small to make any firm conclusions. There have been some larger studies which also show similar response, some improvement in the scarring, but it hasn't been the primary endpoint of a trial. And also the trials are not really big enough to be able to make firm conclusions to change our current practice. I did mention about the Fedora trial, and that's using interferon in combination with fedratinib, and I know they're looking at the response in the bone marrow. So we really need larger studies, and it might be that it's used in combination to show this benefit.
Thanks so much. And then maybe a question for maybe Anna or Andrew about vaccination approaches for myelofibrosis or other MPNs. Do either of you want to comment just a few words on the CALR-directed approaches we're looking at?
Only very briefly. There are people who know a lot more about this than me, but yeah, I mean, the idea is that CALR, mutant CALR, makes a very significant change to the structure of the protein, which is not the case for things like the common mutations that we see in JAK2. And the reason that that's helpful is if a protein has undergone a considerable but predictable change, then that potentially allows us to try and harness the immune system to develop an antibody or other immune response against that new protein, because it will appear to be foreign. And that's the principle of immunotherapeutic approaches, of which one is vaccination. And that means that we're now at the stage of trials of immunotherapies for CALR mutated disease. You can imagine that in most of our clinical trials, we often focus these new therapies where the need is greatest, which is often myelofibrosis. But ultimately, if these things work well and importantly are well tolerated, then the hope is that that could be a treatment option for a lot of people. It's a little bit early to say, but we're really, really excited about seeing the results of some of those trials that are coming out.
Yeah, I agree fully. Thanks so much, Anna. So there's been a lot of questions from everyone asking about transplantation for myelofibrosis, and also a few questions in the chat. So as groups of haematologists and transplant doctors, we have a set of guidelines that we follow across Europe and globally about who and when we think about transplant for myelofibrosis, because no matter how any patient is as regards age and fitness, there's still always a risk as regards undergoing an allogeneic transplant. And by allogeneic transplant, I mean when a patient has high intensity chemotherapy to wipe out myelofibrosis causing stem cells, but also takes away the normal stem cells in the bone marrow, and then receives an infusion of stem cells from a matched or very ideally closely matched donor, which can either be often a brother or sister, if they happen to be a match, or someone who's found through the Anthony Nolan registry. And that is, no matter how fit we are, what age we are, a very intensive procedure to go through, because as a patient undergoing a transplant, you need to have a lot of workup tests to make sure the body is fit enough to receive that intensive chemotherapy and immune therapy. You need to have a donor. So that may either be the brother or sister, or sometimes a half-match donor within the family, or through Anthony Nolan or other related registries. But the transplant period itself means about 4 to 6 weeks in hospital. Often that can mean when you're discharged, you're coming back to the hospital 2 to 3 times a week. And it's very, very common, particularly in the first 3 months after transplant, to need to come back into hospital. So how the transplant works is the chemotherapy takes away as many of the myelofibrosis causing stem cells, but the fibrosis is still there. When the donor cells come in, as Alesia said, we like the spleen as small as possible before the transplant, because many of the stem cells can get eaten up within the spleen before they find their way into the bone marrow. And then over about a 14 to 16 day period, the donor stem cells start to crosstalk to the bone marrow, and then they divide and cause healthy blood cells to come back. And then over time, but I'm talking up to a year, a healthy immune system to come back. And as the new immune system comes back, it's actually the donor's immune system that if any of the myelofibrosis stem cells wanted to wake up and cause the disease to come back, it would recognize it and ideally destroy it and prevent a relapse after transplant. So we reserve transplant in general for people who have intermediate to high risk or very high risk disease. For people who've got accelerated or leukemia after myelofibrosis, it is a very tricky disease to treat. But again, we would want to give chemotherapy, usually several months of chemotherapy before the transplant, to reduce the number of early cells in the blood and bone marrow to give the best chance of success with a transplant. So you can hear from that very short introduction, the transplant bit probably applies to only around 10 to 15% of people with myelofibrosis, and often those with intermediate to and high risk disease. Someone asked me about survival, but that's a very patient-specific figure that needs to be discussed with your team, because there are lots of factors. It depends on the patient, if they have other health problems, the type of donor, the type of transplant. But often if you fall into that group and you're considered transplant eligible, it'll be just something to discuss with your haematologist and perhaps have a chance to discuss with a transplant specialist. And often he or she may be the same person. We had a really interesting question that all of us were scratching our heads slightly on, about how many people in the world have myelofibrosis. So it's interesting, we don't capture that data very well. As a group of physicians in the UK, we're ideally trying to set up a myelofibrosis registry, which means that every patient with myelofibrosis would be registered, and then we could answer that. But in brief, you see slightly different figures if you look in UK, Europe data, and America, but we suggest that maybe 0.5 to 1 person per every 100,000 of the population. But on average, there are probably, if you look at what we capture through our registry data from our hospital systems, there's about 300 or more patients with myelofibrosis diagnosed each year within the UK. But I think as we get better with our electronic health systems, we'll hopefully in the next few years be able to answer this question a bit better. But it's hard to capture because the details are captured in many, many different systems that don't always talk to each other. So it's coming up to 5 to 6. I would really like to take this opportunity to thank Alesia, Anna, Andrew, and most importantly, Dawn, for sharing their talks today, sharing their experiences, and most importantly to all of you for all of the fantastic questions that you submitted, and for MPN Voice team for supporting to bring us all together this evening. And I'll hand over to Nona. Thank you so much.
Thank you all so much. I think it's been an amazingly informative webinar, and we're extremely grateful to all of you for giving your time to do this of an evening. There's one last thing to really say. donations. If you've enjoyed this webinar, I wonder if you would consider donating to MPN Voice and supporting the work that we do. We do have to raise funds for running the charity because we are all volunteers. So every single penny counts to help develop the charity. There is a Just Giving, Maz has linked up here, the Just Giving contact and also the QR code. And finally, I would like to thank Maz. This is the first time she has facilitated a webinar on her own. And in spite of all her nerves earlier this afternoon, Maz, you've done a fantastic job. And stay safe. And we look forward to seeing you all at our next webinar. Thank you so much.